Okay, so it's time, so we can get started. Good morning, everyone, and welcome to our ED MOUD peer-to-peer learning collaborative. Very excited that everyone's here today to join us virtually. My name is Clarence Brucker, and I work for the MHA Keystone Center. If you're not familiar with MHA, we support hospitals, health systems, and health organizations statewide on a variety of initiatives such as this one. With me are also our partners from CFSEM, the Community Foundation for Southeast Michigan, and we're really excited to collaborate with them on this. These collaboratives are a way for us to work with peer-to-peer learning opportunities to increase awareness for ED, MOUD work and decrease opioid-related injury and death in Michigan. For those of you on the call, this is your chance to ask questions, engage with our guest clinicians, and to ensure a smooth and productive discussion, if you could type your question in chat or use the raise hand feature if you would like to ask a question. Once selected, we'll be able to unmute you and you can ask your questions directly. And with that, the first learning collaborative, Treatment Principles for Opioid Use Disorder. It's my pleasure to introduce today's featured clinicians. Dr. Nicholas Rodemaker from Trinity Health, Grand Rapids, is a board-certified emergency physician working in Grand Rapids. He developed an interest in addiction medicine while working in Baltimore and Flint for 7 years during the start of the fentanyl-induced opioid overdose epidemic. In 2020, he started working as a technical assistant for the Michigan Opioid Partnership and has assisted at least 75 emergency departments in Michigan as they worked on their medication for opioid use disorder treatment pathways. Dr. Jacob Mantefol is board certified in emergency medicine and addiction medicine and is practicing at the Henry Ford Hospital Emergency Department in Detroit, Michigan, where he serves as the Director of Public Health. He is the physician champion for emergency department medications for opioid use disorder programs across Henry Ford Health. He is also a principal investigator for the National Institute of Drug Abuse funded ED innovation trial in the treatment of patients with opioid use disorder with emergency department initiated buprenorphine. He's a core faculty in the Department of Emergency Medicine residency program at Henry Ford Hospital, and his educational focus is on mentoring residents in research and quality improvement projects in public health, including opioid use disorder. Dr. Rodemaker and Dr. Mantefol, thank you for joining us and looking forward to this presentation. It's all yours.
Thank you.
Thank you, Clarence. I'm going to go ahead and try to advance the slide here. There we go. So yeah, I think Clarence, that was a great introduction. I appreciate that. And our goal today is to have a very broad overview of the basic treatments of opioid use disorder. We'll hit on a lot of the highlights, that we will emphasize in future collaboratives, but this is more of a basic overview of the basic principles of opioid use disorder. So disclosures, both of us are technical assistants for the Community Foundation for Southeast Michigan. However, we do not receive any financial benefit from the prescription of medications or the treatment of opioid use disorders. So as I mentioned, we want you to understand the pharmacology of methadone, naltrexone, and buprenorphine at the end of this collaborative. Also to know the major common steps in ED MOUD treatment pathways, and to grasp the advantage that MOUD provides those with OUD with long-term therapy. So I know most are aware that we are in the midst of a national opioid epidemic, and certainly severe in Detroit, in Michigan as well, all across the state. The trends in overdoses and deaths have been increasing over the past several years in an exponential fashion. In the graph on the left on the screen here, you see that in 2020, opioid overdoses accounted for almost 70,000 deaths, and this is extrapolated data on the right, and we believe that by the end of 2021 or 2022, we're approaching 80 plus thousand deaths per year from the opioid epidemic. And there is some leveling off of the overdose deaths in some communities. However, in some of the more underserved communities, those rates continue to increase. So overall, we have a huge problem on our hands, and that's partially why we're talking about this today. So in terms of the treatment of opioid use disorder, one of the huge barriers that was overcome back in January of 2023 was the elimination of the X waiver. And that was a special training that clinicians needed to have in order to prescribe buprenorphine. And that was a huge barrier for programs starting ED MOUD programs because you know, doctors, PAs, residents weren't allowed to prescribe buprenorphine unless they had this special waiver. And it took special training, either 8 hours of training in the beginning of a continuous SUD training. Thereafter, there were some shortened versions of 3-hour training events. And that just became a paperwork hurdle to get over, but still a barrier. And that was completely eliminated in January 2023. So now any person that has a DEA license can prescribe buprenorphine. So that includes a brand new resident that has a training DA license through their institution. Any PA, NP, or physician that has a DEA license can now prescribe buprenorphine. So the trade-off for that was that providers will need to have 8 hours of SUD related training before they can recertify, or they need to attest to that before they can reapply for their DEA license. So there's an expectation that providers will get education on this topic, and however, the huge barrier of the X waiver is now removed. And we can't talk about opioid use disorder without talking about stigma. And we have a whole safe table discussion dedicated to this. However, I think it's worth mentioning at least for a minute or two here. And the reason why we say opioid use disorder instead of opioid addiction, or someone is an addict or a user or a junkie, is because words matter and stigma is real. And providers, clinicians stigmatize their patients, and patients stigmatize themselves. And what we all need to realize is that addiction is a disease, and we need to treat it as such. And it's not unlike any other chronic disease that we see and treat, like diabetes. And when a patient comes into our emergency departments and they have high blood sugar, we don't shame them. We simply give them the medication necessary to lower their blood sugar and make sure everything else is medically appropriate. And we advise or arrange follow-up for them as an outpatient. And that is the model that we should be using for opioid use disorder, as it is a chronic disease which will relapse. We do know that. And we do our best as providers to control the disease and to provide the medications when needed and to connect patients to resources. So there's a lot more to be said on that, like I mentioned. However, we just need to remember that these are patients that have a disease and we need to treat them. Another acronym that's thrown out is the MOUD, and we've mentioned that already. And that stands for Medications for Opioid Use Disorder. And that's the kind of the more in fashion name for medication assisted treatment, or MAT. And the emphasis is that medication alone can be the treatment. In other cases, patients do need combined wraparound services, therapy. But MOUD is now the preferred terminology for the treatment of opioid use disorder. So this is a white paper that was put out by the American College of Emergency Physicians. And this is just to kind of reinforce the point that we are not cowboys here. Nick and I, these are not crazy ideas that we've come up with on our own. This is a white paper by the American College of Emergency Physicians describing their position on buprenorphine in the emergency department. And there are consensus recommendations. This is something that we should be doing for our patients. These patients have high mortalities. They, when they come in for overdose, they can be anywhere from a 1-year mortality of 5 to 15%. So these are sick patients. They are very much in our wheelhouse in emergency medicine, and we are happy to take care of them. So moving on into a little bit of pharmacology, this is a little graph which shows the effects of opioids on the left side, and on the lower, the x-axis is the dose of the medication or substance. And what we're seeing here is that you have buprenorphine, which is a partial agonist for the mu receptor, and it has a ceiling effect on its opioid effects. So that includes a ceiling effect on respiratory depression. There's a ceiling effect on the high that is achieved, and there essentially isn't one. Whereas full agonists like methadone or heroin or morphine do cause a respiratory depression and can cause that euphoric effect that you see with the opioid receptor agonism. And on the bottom, we have the opioid receptor antagonist. And so naloxone is what is mentioned there. Naltrexone is another opioid agonist that we'll mention later on here. And so what we have essentially is a high affinity medication in buprenorphine, which can displace the agonists methadone and or morphine or heroin. And so we have to be careful when we use that, and we'll talk about that more as we go along. So some of the highlights of methadone. As I mentioned, it's a mu opioid receptor agonist, but it has a low affinity for the mu receptor, and it can be easily displaced by buprenorphine, which can become a problem when we talk about precipitated withdrawal. The initial dose of methadone is usually about 30 milligrams with a slow up titration. The issues with methadone is there are risk of loss of retention. It can cause sedation, and it can also cause overdose during the induction phase. It does have a long half-life. It's generally in the system for 48 to 72 hours after taking the medication. And most patients, when they are maintained on methadone, are usually in the dose range of 100 to 200 milligrams. However, it's very person dependent, and a lower dose of methadone is not necessarily a better dose of methadone. A little bit more about methadone. As I mentioned, it can cause sedation and respiratory depression. It can also cause those side effects, especially when used with other sedatives or opioids. It can cause the prolongation of the QTc on an electrocardiogram, so you have to be careful with that. And it must be administered in special clinics, usually daily. Patients that are taking methadone are showing up to a methadone clinic daily. And however, after a period of quote unquote good behavior, patients can be prescribed this medication. But for the most part, patients are showing up to a methadone clinic daily for their doses. And one of the issues clinically that we do see when restarting methadone, and one of the things to be worried about, say you have a patient that comes to the ED and they have been taking methadone in the past, and they might be experiencing some withdrawal side effects. If you go back to their long-time maintenance dose, you will definitely potentially cause overdose or respiratory depression by providing that medication. So you generally need to restart at the lower dose, 30 milligrams, especially if the patient has been off the medication for some time. Moving on to naltrexone. Naltrexone is a full high affinity mu receptor antagonist. And there are some trade names for this, but we won't mention. However, it does come in an oral version as well as an extended release intramuscular version, which can last anywhere from 25 to 50 days. The oral version is usually 50 milligrams orally daily. And it extinguishes both the positive reinforcement of opioids and alcohol. And it's actually a very common and popularly used medication for alcohol use disorder. The person that's starting naltrexone must be opioid abstinent for days to over a week to prevent precipitated withdrawal. So as we go back to that pharmacology curve, in the lowering effect of displacing any opioids or even buprenorphine on that mu receptor curve will make a person sick. And so you have to make sure that all opioids, including buprenorphine, are out of their system before starting naltrexone. It is a good option for those that had been on methadone or buprenorphine. for a long period of time, but they no longer want to be on opioid replacement therapy. So they know they're still at risk. However, they no longer want to use an opioid for the management of their opioid use disorder. And I actually had was on the receiving end of a lecture yesterday of a specialist that uses naltrexone from time to time. And she had recommended that, or suggested that this was common for professionals that needed to or did not want to be on opioids. So doctors, nurses, airline pilots, those kind of professions are popular choices for naltrexone. And definitely is an option for somebody that's been off of all medications for a while. So if they were in an inpatient detox facility, for example, and didn't have any opioids for a period of a week or 30 days even, those are good candidates for naltrexone, and also those that are in an incarceration setting that are not getting any medication prior to release. So moving on to buprenorphine, this is a high affinity partial opioid agonist, and it has a long half-life when used to prevent overdoses and cravings. It's also used to treat pain and has analgesic properties, which are shorter lived in terms of their half-life in a 4 to 6 hours. However, when used like I said, for opioid use disorder to prevent cravings, the medication works for usually 12 hours, if not 24 hours for most patients. And there is this ceiling effect, if any effect, on respiratory depression. We'll look at a slide looking at a graph of the effect of buprenorphine on respiratory depression. It's commonly given in combination with naloxone. So there are some trade names here which are blurred out, and we'll leave them out of the presentation, but it's a commonly used medication. We do like the combined product because it lowers the diversion potential. And if you were to take one of these buprenorphine films and cook it up in a spoon and inject it, for example, if you have naloxone combined in that, which would have 100% bioavailability via injection, you're essentially injecting the antidote for opioids. And so that's not a popular thing to do. And and so that is the preferred way to prescribe it if you're sending a patient home with a prescription. Next slide here. So as I mentioned, this is kind of highlighting the safety profile of buprenorphine. This is a graph buprenorphine buccal films, which is what you can see here, 300, 600, 900 micrograms, and there is no effect on respiratory depression. However, you compare this to oxycodone, 30 or 60 milligrams, and you see the marked signs of respiratory depression. So the overall point here is that this is a safe drug from a respiratory depression standpoint. You do have to be a little bit careful if you have a patient that it has a concomitant benzodiazepine use. That is one scenario that can cause some respiratory depression. But on its own, buprenorphine is a very safe drug. And apologies, I blew this slide up a little bit because the figure was very small, but this is really fascinating to me. This is a study done in 2016 looking at patient responses to injections of 6 or 18 milligrams of Dilaudid, as hydromorphone as Dilaudid. And so this is looking at patients that are on a long-acting injectable buprenorphine product. So this is their baseline 3 weeks prior to their injection. If you give them this 18 milligrams of Dilaudid injected, they have a high drug liking or visual analog scale score. So, and this is at the baseline, and then after they've been on bup sublingually for 1 week, and then after a week after the injection and going out 12 weeks, if you give these patients this high dose Dilaudid injection, they are feeling no effects of the medication. So it's buprenorphine is protectant when it's at a level of essentially 2 nanograms per ml in the bloodstream on patients using. So they essentially don't get any of the euphoric effects if they were to use. So kind of makes it a waste of time and a waste of money. And so this is a fascinating slide to me, and I guess just highlights, again, the safety of the medication. And I'll pause for a minute and see if there's any questions. Please chime in, but otherwise I will turn the slides over to Dr. Rademacher.
Thanks, Jake. Does anyone have any questions? I think this is a good time for questions, because if no one else does, I have a couple of questions for Jake.
I'm happy to take your questions, Nick.
All right. Have you ever prescribed buprenorphine for pain?
I have not, no, but I have seen patients that have been prescribed that. And
Yeah.
I think it's a reasonable option. I think sometimes you're having that conversation with the patient that, maybe obtaining oxycodone, for example, illicitly to treat pain, and I never want to discount a patient's pain, and I always wonder if sometimes some of that pain is due to opioid withdrawal. And so sometimes it is a 2-for-1 where, you're addressing pain. I know it's effective, and you're also addressing the opioid withdrawal and taking away the potential serious side effects of the pills or other opioids to be used.
Yeah. That's what I think most of the time our patients that are being treated have patches on. So it's like a long acting infusion, and it's pretty beneficial to them. I think it's a really good option. I wish more pain clinics would use it because of its safety profile. I think I've done it once or twice in the exact situation you described, where they seem very much like they're an opioid withdrawal, but they don't technically have an opioid use disorder, right? They just are someone who has chronic pain, usually a couple weeks after a back surgery, where they're escalating doses of opioids, and it seems like it's not going very well. And I've talked to them about it and said, I think, maybe these opioids are actually making your opioid receptors more sensitive, and we need to block them. And they've been pretty happy with it the couple of times I've done it. So kind of a rare thing, but at least from the emergency department, but it's been a tool I've used. One other comment, and I think it's exactly right that naltrexone is a great option for professionals, right? A lot of doctors and nurses, for example, can't be on opioids, which buprenorphine is an opioid, while they're practicing. And so naltrexone is a great way to reduce cravings and to reduce any bad side effects of returning to opioid use. But last I looked, pilots, even though it would be perfectly safe for them to do so, the FAA does not allow you to fly if you get naltrexone. Which would be, hopefully they've reversed that. I think it was 2 years ago when there was a pilot, someone that was in the session had a pilot's license, and we were talking about this, and they said that you actually would lose your pilot's license if you get naltrexone. So I hope that's no longer true. That was unfortunately true a couple of years ago, but kind of an interesting regulation that we need to work around.
Yeah, I just learned that yesterday. So you've effectively unlearned that from me
Well,
in one day.
maybe I just gave you a black pearl, because maybe they've undone that regulation since the last 2 years I looked. But last I know, we wouldn't want to tell our pilot friends that they should be on naltrexone and then get them fired. All right. So I'm Nick Rademacher. I'm an emergency physician in Grand Rapids, newly certified addiction medicine physician as well. But I've been doing this for, I think in 2018, I started working with buprenorphine in Flint. So it's been a fun couple of years, and I look forward to the next hour or so to talk about how we can best utilize these tools for our patients in the emergency department. I'm going to talk about how to actually get into these protocols. And one of our overriding principles is to do no harm. And so one of the main things we're trying to do when starting someone on buprenorphine is to make sure that they're an appropriate candidate. So Jake had talked about precipitated withdrawal a little bit. I'm going to expand that, but that's really the risk that we have to address when we talk about starting someone on buprenorphine. And so what we need to do is make sure that someone is adequately in withdrawal, because if someone has opioids adhered to the mu receptors, when you start them on buprenorphine, the buprenorphine will remove the opioid and suddenly take them from a euphoric state or intoxicated state into a non-intoxicated state, and that'll make them feel as if they're in withdrawal. And so we use this clinical opioid withdrawal scale, which is similar to CWAD, which we use for alcohol withdrawal. And this all looks very complicated and intimidating, I think. But honestly, I take my phone out in the patient room and I just say, hey, I'm going to pull up this thing and make sure that you're in enough withdrawal. I hope you don't mind. So no one memorizes this. I don't have the paper. I just bring it up. We're not supposed to use any specific websites or promotions, but it's a very commonly used clinical tool. The website that I use has it. So it's there if we need it. The basics for all of these pathways make it so easy, and that we don't need any labs.
Nick, can I interrupt you for a minute?
Yeah.
So for the cows in particular, and I do the exact same thing. I do my cows every single time at the bedside, because I think the major thing on about the cows is it's so subjective. You have to, you can't just sit down after a patient encounter and calculate their cows. You have to physically ask them, how are you feeling? Are you feeling nauseous? And there's all these degrees of, what they might be feeling, or do you have a stuffy nose? That's not something that I can tell on a physical exam. And so because the cows is so subjective, I do the exact same thing every single time. I use it on my phone, and I do it at bedside. So I think that's the key. I've seen other providers kind of stumble at times when they've calculated the cows, and they're like, oh, their cows is only 5, they're vomiting. And the reality is, if they're vomiting, they're probably in a moderate to severe withdrawal already, and they're probably not adding up the other points that they would have gotten for that.
Definitely. Good points. So other than not needing labs, the medication is sublingual, meaning that the patients who are dehydrated from vomiting or tremulous from their withdrawal, or having track marks and scar tissue throughout their upper and lower extremities from prior IV drug use, you don't need an IV. You just put the medication under their tongue. And so it's really easy in that way. And then we're going to go through a couple different pathways, but there are, you can use different cows. So you can start at different clinical opioid withdrawal scales and give different doses of medications. But the most important system-based principle here is simplicity. And that if this is complicated for your providers, they're going to be hesitant to do it. And you don't want to do anything that's complicated and intimidating. And so in general, I recommend that if you're doing a clinical opioid withdrawal scale of 8 or greater, that you give 8 milligrams of buprenorphine, because it's one number, right? It's just a score that's 8 and then a dose that's 8. And you also want, I didn't have it here, but you want the buprenorphine to be in combination with the naloxone, because that's what you want to discharge people on. And so if your providers have to remember to order the isolated buprenorphine in the emergency department, but then they're transitioning to a home dose with naloxone in it, it's just 2 things to remember. Right? So I really think that you do one number, you do one medication, and it just makes it easy for everyone throughout the pathway. The other thing is that sometimes patients will tell you that they're allergic or have had reaction to the combination strips or tablets with the naloxone. So what's happening is that many patients have tried to take buprenorphine from their friends or even from their drug dealers. When the drug dealers run out of drugs, they'll give them buprenorphine in order to treat their withdrawal until they can get another shipment in. And so patients will not be guided about how to take it. They'll take it too early and they'll get precipitated withdrawal. They think that withdrawal must be from the naloxone because they associate withdrawal with naloxone. But when taken sublingually, the naloxone is inert, and so they're actually just in withdrawal from buprenorphine. But they'll come in and tell you, I've taken the buprenorphine with naloxone before, and it made me sick. And so it's kind of nice to give them the buprenorphine naloxone combination formulation in the emergency department when you're monitoring them, so you can show them that when done appropriately, that naloxone doesn't actually make them sick. It was the buprenorphine last time. And that way you can give them a trial and treatment dose in the emergency department, and they'll feel confident to take it upon discharge. The fourth important principle for your protocol is that you want to ensure adequate dosing. This is very counterintuitive because in general, the guidance for medications is to start low with your dosing and increase slowly. And that's what we do for almost all medications. But buprenorphine is actually the opposite, in that if you underdose people, you actually increase their risk for withdrawal, and you increase their risk for loss of retention and treatment because their cravings and their withdrawal symptoms are not satisfied. And so they'll stop and they'll go back to using illicit opioids, which we know are extremely dangerous right now. So make sure that your protocol is one in which people get adequate doses, which is typically at least 16 milligrams prior to discharge. For long-term success, we include a lot of support. Every emergency department is different in regards to their staffing and capabilities of social workers, case managers, peer recovery coaches. They're called clinic navigators in some systems. But once the patient's in the emergency department, we want to kind of blanket them with support people. And so that when we set them up for treatment and success in the emergency department, they know their next step. They know which pharmacy they're going to. They know which clinic they're going to and at what time their appointment is. If you have the luxury of having recovery coaches that can meet someone in the emergency department, develop a rapport, and then call them the day before their appointment and make sure that they're going, that they have a ride set up, that they were able to fill their prescription, that these protocols are going to be much more successful than protocols without adequate support. And then the final concept is the warm handoff. I think a lot of times we're used to saying, you have a fractured wrist, call the orthopedic clinic tomorrow morning to get an appointment in a week or two. And that's a cold handoff. They're in charge of calling. And a lot of times I think that's okay. I think we should acknowledge that those with opioid use disorder do often have a whole separate set of other psychosocial pressures, and that this is one group that we should be really supportive of, and make sure they leave our department with a clinic and appointment set up. So this is helpful because that way they don't have to call, they just have to show up, and it will let you know how long you should prescribe them for. If they are going to be having an appointment in 3 days, then you can prescribe for just 3 days of buprenorphine. If their appointment isn't for 2 weeks, well, then you wouldn't want to just prescribe for 1 week. You would want to prescribe for the 2 weeks so they can get to their appointment with medications to last that long. So these are the basics. We'll kind of go through a couple different protocols here.
Nick, look, if I can chime in again
Sure.
there. So one of the beauties of these protocols is they are very simple, and sometimes when you're seeing resistance with particular clinicians or even leadership when you're trying to implement a ED/MOUD program, I think that the fact that these patients who are coming in ill appearing may just need a sublingual dose of medication and not a CT scan and ultrasound guided IV or a central line to get appropriate access for your CT scan. That's one of the selling points, is that you're actually being more efficient in your care. And, not only that, you and I know that these patients are very appreciative when they do look and feel so bad, and in a relatively short period of time are feeling much better, are thanking you, and you're meanwhile arranging for their disposition. And the whole process actually goes much more smoothly and efficiently when done correctly. So knowing how to recognize opioid use disorder and treating withdrawal actually makes you a better doc and makes your ED more efficient.
I think definitely. I think the percentage of thank yous and hugs I get from the patients I've started on buprenorphine is higher than any other group. I think close second is probably urinary retention, but otherwise, this is far and away the most rewarding patient cohorts to treat. So this is a official pathway from the California Bridge program. They're probably, as far as I know, the largest system. It's all through the state of California. And this is on their website. And I often consult this when I'm on clinic or I'm in my shift. And you just need to identify someone who has opioid use disorder and is in withdrawal. So you use the clinical opioid withdrawal scale, usually on my phone. And one of the tricks too is, as you get more comfortable with this, sometimes you can just tell, right? If someone's super sweaty, tachycardic, throwing up, like, I don't really need to calculate your withdrawal scale. Like, I know what this is. I wouldn't do that the first couple times you do it, but when you've been doing this for a while, you know when someone is sick enough from opioid withdrawal in which they can get buprenorphine, and you know when to question whether or not they are. The other thing is, I think they probably left out, do a clinical opioid withdrawal scale or score here, because a lot of times patients have had a lot of experience with buprenorphine and opioid withdrawal, and they've started it themselves many times, either from a clinic or from the street. And if they've done that, I'll just say, like, are you sick enough to start? Because they've done it before, and they'll say, yeah. And, if it kind of matches up with them looking unwell, then I'm not calculating anything. I just know that that's true. If they've never done it before and they're lying there with their eyes closed and they say they feel sick, then I'm probably going to get out my calculator and make sure, because I'm pretty skeptical that it wouldn't cause them some harm if I gave them a dose at that point. But the truth is I'm not doing a score on every single start. There are some cases when the patient has experience, they look sick, I know that that score is greater than 8. But the safest thing to do is to do the score. You'll see here that their first dose, this blue box, is 16 milligrams sublingually. Others have lower doses. I think that this group's opinion, and I think they backed it up with several papers, is that the higher your dosing, the less likely you are to have precipitated withdrawal. Because if you give a small dose of buprenorphine, it's going to remove the other opioids from the mu receptor. But if it causes some precipitated withdrawal, it's unlikely to kind of also treat it, right? You remove some opioid, but you're not occupying all the opioid receptors. Whereas if you give a high dose, like 16 milligrams, you may remove some of the fentanyl that's on the receptor, but you're also treating that withdrawal by saturating the receptors. And so I think this is probably the safest way to go, but I think this is one of the bigger questions that has yet to be answered fully in the addiction medicine world. After 30 to 60 minutes, you reassess them. In general, within 5 to 10 minutes, you're going to know if this is going to go very poorly. And about 1 to 2% of patients do have withdrawal from this. The other 98% will feel better. And then you talk to them some more. And in general, you want to make sure that they have enough of a dose, as we had mentioned. And so you give that second dose. My home protocol is 8 milligrams up front. And so then after they start to feel better, I give them another 8 in 30 to 60 minutes for a total of 16. In this pathway, they're starting at 16, and then they're doing another dose to get, I think, to 24 is their goal. So they're just going in the higher end. And I think that's great. That's totally fine. It's not been exactly what I've done, but I may move there in the future. And then discharge summary is to give them at least 2 weeks. Now, you don't have to give them that much if you know that they're getting to a long-term provider in a shorter period of time. The other thing that this pathway does a really good job of is talking about what to do if someone's not in withdrawal. So if we go all the way back up to the top, it's the self-directed start. And so every patient I have with opioid use disorder is going to get buprenorphine. I think the first 2 or 3 years that I did this, I would tell them to come back because I wasn't comfortable for some reason prescribing buprenorphine for home starts. I thought they couldn't do it, that they would have complications. The truth is that people are doing this by themselves frequently, and I think it goes wrong a fair amount of time because they don't know exactly what to do. But with our guidance, I print off a sheet, explain what their symptoms should be. I usually just say, wait until you can't wait another minute, right? If you feel so sick that you have to go and buy fentanyl or inject heroin, then that's a perfect time to use your buprenorphine. Just wait as long as you can. That's going to be the safest thing to do. And then I give them a prescription. So they don't get a dose with me. They don't go through this protocol. If they have an opioid withdrawal scale less than 8, then I write a prescription and I still do everything else the same. They still get a warm handoff. They still get their Narcan kit. They still get everything else. They just don't get a dose with me because I'm afraid it'll make them sick. And that's one pathway that this California team does really well. Here is the pathway from the Yale group. And this is the group that kind of started this all back in 2015, showing that patients that got buprenorphine in the emergency department were much more likely to be retained in care, I think 3 months out. And so this is kind of the original. And just so this is what's out there. It's different than the prior one. Again, this one isn't my preference. This is more on the conservative end. The last one was more on the aggressive end. I'm somewhere in the middle, but I think this would be fine too. And so they guide you to, again, look for opioid withdrawal and their situation. So they go from 8 as well. So if they're less than 8 for the withdrawal scale, then they don't give them a dose. And they talk about waivered providers, which we don't have to worry about because the waiver is gone. And then they give them a prescription. So that's standard practice. I think if your withdrawal score is greater than 8, then they give them a dose in the emergency department. They do 4 to 8 milligrams. I always advocate for the higher end, so probably 8. And then they observe for a while and then give them another dose to make sure that their dose is adequate and discharge with a prescription. So I think the bones of these protocols are all very similar. You can have some debate about some of the dosing, about the withdrawal scale, about how long you prescribe for, but no one's advocating that I've heard of that you should be getting a full set of labs. The only test that may be helpful is a pregnancy test, because if someone is pregnant, then you'll want to refer them to the right place, because it's often the high-risk OB team, the maternal fetal medicine groups that do buprenorphine in the emergency as an outpatient for pregnant patients. So that's why a pregnancy test is helpful, but you don't have to do it before you give them the dose. It used to be that we would prescribe isolated buprenorphine rather than the combination for people that were pregnant. And that's no longer the case. It's perfectly safe to give a combination medication to pregnant patients as well. So really minimal labs throughout. It doesn't need an IV for any circumstance. And you can, give these sublingual medications, you observe for an hour or so, and then make sure that they get follow-up care and they're out the door happy. It's great.
Nick, I wanted to emphasize your point on the patient's own experience in terms of their COWS scale, and sometimes not even needing to do a COWS scale because the patient is so experienced that with withdrawal that they know that they're in a severe withdrawal, and typically cows, like I said, can be very subjective. I've done a cows at 4 a.m. before, and the patient is yawning, and I was giving them points for it. And I probably should have deferred to her opinion in those. And it is just like a lot of things in medicine, a shared decision-making experience. And how do you feel? Are you feeling bad? Are you feeling like you're in pretty bad withdrawal? And that should match your cows. So if they're in a mild withdrawal, you're really best off waiting, even if you've gotten to the appropriate number on your scale. And you could do the home induction if that's appropriate. But the patients know almost all the time when it's time. And so I think that's an important thing. We like to use our numbers and our calculators, but like listening to the patient, I think, is probably the most important. And you can, back it up with your cow scale most of the time.
Yeah, I think there's some special circumstances that I've had is, patients who are almost in enough withdrawal, right? They have a cows of 6 or 7 or maybe even 8, but they're in police custody, right? They got arrested. I'm not going to send them out with a prescription. I'm going to wait, right? I'm going to hold them for 4 hours until they're sick enough, and then I'll give them a big dose, and then they can go to jail because I know they're not getting that prescription in the next 48 hours. And so if you decide to discharge them then because they're not in enough withdrawal, then you just set them up to be sick for the next 24, 48, 72 hours in jail, which really isn't great for anyone. Or you can wait 4 hours until they're more sick and then give them a dose. And so, there's some nuance and patient specific factors, but a lot of times just listening to what the patients say they're ready for is the right and easier move. It's just, just easier to do. This illustrates the concept of precipitated withdrawal. And so if you think about, looking at this graph, a full agonist is like a morphine or a fentanyl. That receptor is fully activated. And, often patients who have opioid use disorder, they don't even necessarily feel that euphoric or off their baseline when they're on fentanyl because they just shifted to that being the norm. So if they look normal, but they've used recently, and then you come in and give them the buprenorphine partial agonist and move them from that full agonist position to partial, it's a relative change that feels like withdrawal, or it is withdrawal, but it makes them sick. So that's the concept. And I've explained this and basically used this graph with patients on the whiteboard in the room many times. But if you wait long enough, that full agonist, right, it crests and then it goes down. And so you have this, bell-shaped curve. And I explained that once that bell shape gets below where that blue line is, then when you get a dose, you actually increase their mu receptor activation and make them feel less sick. And so that's what we're waiting for, when those lines cross. And I don't know if they're just being nice or not, but most patients seem to tell me they understand that. So this, is what most people fear, patients and providers alike. We don't want to make people sick. But the nice thing is we can treat it, and the emergency department is a very, very controlled and basically a critical care setting. And if you can get someone really sick, you can manage it. I think one of the most influential pieces of advice I've gotten from one of the addiction providers is that if opioid withdrawal is the problem, in which this case, right, it's precipitated withdrawal, but it's still opioid withdrawal. If it's just from lack of opioids, if it's from naloxone, if it's from naltrexone administration, if it's from buprenorphine, if opioid withdrawal is the problem, the treatment is always buprenorphine. It's the same. So you just give them buprenorphine quickly and usually in large doses, and then you absorb or you activate the receptors and try to get them out of withdrawal. You can add things like clonidine, ketorolac, ondansetron, methocarbamol, ketamine, benzodiazepines if needed under monitoring circumstances. But those are really for symptoms. The main treatment is going to be more buprenorphine. And then you have to watch them for a while to see how they do. This is again, from the California team. This is how they treat their buprenorphine precipitated withdrawal. And so they, again, give 16 milligrams sublingually, and then they also give 2 milligrams of lorazepam. One trick is I always tell my patients, and I have yet to have a precipitated withdrawal happen to me. I'm sure it'll happen sometime because it's hard to predict. But I tell them, if this medication makes you sick, then it's going to seem funny, but I'm going to come in and want to give you a lot more of it, because I don't, want them to get sick and then say, I'm never taking that again. And then I try to come at them and say, I'm going to give you a bunch more of the same thing, which made you sick. So I prepare them so that if it happens again, that hopefully they'll be more accepting of taking a bigger dose of the same thing that just seemed to make them sick. So large dose of buprenorphine, some benzodiazepines, and then 30 minutes later, reassess. How are they doing? If not any better, you can give 16 more. So, I mean, if you gave them 8 or 16 and they got sick, sorry, the second dose is 32, right? And then the next one is 48. So, I mean, you might be giving a large dose of buprenorphine. We've heard, murmurs that people have given the 60s, 70s, 80s range of milligrams of buprenorphine. Obviously, you want to do this in a monitored setting, but Jake showed the graph. In general, you don't get much at all respiratory depression with buprenorphine. If you do start adding a lot of benzodiazepines, you'll probably see it. But I think you can be aggressive and treat the withdrawal. And then the nice thing is that once the withdrawal goes away, the precipitated withdrawal, they've gotten a large dose of buprenorphine and they can just continue to take it, right? The hard part's done. And then you just, you follow up with care. You don't necessarily need to be admitted. You can just go home. So in this blue box, they're talking about people that get really, really sick. Like, I think, hypertensive emergency, severe tachycardia, continuous vomiting. In those patients, you can kind of escalate things to include ketamine. You can use high doses of other opioids if you really need to. Like, this is causing a lot of secondary problems. You could start giving fentanyl in large pushes. There's a note there that in some cases, they've used greater than 2,000 micrograms of fentanyl. Obviously, this is going to make a lot of people nervous, but no, this is, like published recommendations. You're going to want them in a very monitored setting, right? This is almost kind of like a sedation type of situation. That's probably what I would do, honestly, is call my sedation team down to help. But treatable, and I think something that emergency physicians should be comfortable with.
Nick, I have a little bit to add there. So that you brought up a good point about needing to escalate doses of fentanyl in order to overcome withdrawal or pain. And so if you have somebody that's, say, on Sublocade or sorry, I shouldn't use a trade name, a long-acting buprenorphine product, or is taking regularly prescribed sublingual buprenorphine, and they have a situation that requires opioid administration, like they were in a severe trauma, and you need to put them on a fentanyl drip for intubation and things like that. The way to manage those situations is to use high doses of fentanyl. And so much higher doses than you would ever be comfortable giving, and just titrating for analgesic effect. And so, 200, 300, 400 micrograms of fentanyl is the doses you would expect, whereas in a regular patient, you might give 25 or 50 for analgesic purposes. So if you're ever in that situation where you have somebody that's appropriately well maintained on buprenorphine, and you must give opioids, obviously you want to try to use other strategies, nerve blocks, etc., if that's an option. But if not, that is the modality to go, is you just overcome the buprenorphine opioid opioid receptor saturation with higher doses of a strong opioid like fentanyl.
Yeah, I think our instinct is to be intimidated by numbers and doses, right? We see this all the time with things like blood pressure. But this is another situation where you just look at the patient, and if you're giving pushes of 500 of fentanyl and the respiratory rate is still 20, it's not having the feared effect. And so you shouldn't fear the dose. The doses just don't correlate to what you are used to seeing, because the buprenorphine is essentially blockading the mu receptors, both centrally, right? And so you don't get the significant respiratory depression when taking fentanyl on buprenorphine. So other little tricks is Jake had talked about how stigma is the #1 barrier that we see to treating people with opioid use disorder. It comes from every direction, right? Many clinicians, don't want to be known as someone or a clinic that takes care of people with opioid use disorder. They don't want to give buprenorphine because they feel like that's just, this is a condition that they should just have willpower to stop and just stop using drugs. Why would you keep doing that? You're hurting yourself. They, think it's, they're subhuman in some aspect, and that is also shared by the patients. I think I'm pretty aggressive in trying to treat people with buprenorphine. I would have to guess that probably 30 to 40% of my patients accept my treatment offers. And I think most of that is just from stigma. Patients don't want to be on medications. I think if they start taking medications, then they have to acknowledge that maybe this is a long-term condition they'll have to kind of live with. Many times people will come in and just say they want to stop, but don't want any help with it. And even if you counsel them about how, they can try, and we wish them the best, but the truth is that the pull back to using is very strong. And so, I think stigma really from every direction makes it hard for us to implement these pathways. And then even once we do it, the patients are just more likely than not to decline treatment. And so it's something we have to work on kind of at every level. My first couple of buprenorphine administrations in Flint, we didn't have it in the pharmacy, in the ED pharmacy. And so the policy was that the nurse had to leave the department and walk up to the pharmacy to get the medication because it was a controlled substance. I think my current department has pins that for opioids you can punch in and you can still send opioids through the tube system, but that wasn't how it was in Flint. And so I asked after like 45 minutes why my patient withdrawal still hadn't gotten their medications, and the nurse was just like, well, I have like a septic patient here next to them. I can't just leave and go up to the pharmacy. And so after that, we made the change. We had buprenorphine, right in the, in department pharmacy. And that's been, I think, the best way to go. Otherwise, it just doesn't get done quickly. And the patients who are not feeling well aren't all that patient. And so once they feel like they're being neglected, they just leave, right? And when they leave, they're going to get another source of opioids and use them. And those are much more dangerous. So we would like, the emergency departments to do screening. I think screening's a challenge because people are screened for a lot of things in triage. And so to add one more can be a hard sell. And then again, patients aren't all that open. And so, I'm not sure what the effectiveness is of many opioid screening protocols, but I think it's probably the best thing to do. But overall, if you can't do screening, we just need to make it a more, I think, open disorder that we all can talk about. And so in my department, we can't do screening, but we have signage in all the triage rooms throughout the department that we're open and willing to talk about your opioid use, and so that patients are more likely to bring it up with us. And so we do more of a patient-directed strategy. It's probably not the best, but it's better than not making it obvious that we want to help them. And then the other thing that we can do as providers is just keep an eye out on people's prescription drug management list, like the PDMPs, through your state pharmacy, because you can see what people's prescription patterns are. You can see that they got buprenorphine in the past, and that may be just opening up a conversation about, maybe things aren't going well. You got buprenorphine 2 years ago. It seems like you stopped. Do you want to restart? And so trying to use creative means to diagnose more opioid use disorder that is sometimes difficult to diagnose is best. And then your program will be best served if you have really good, strong relationships with outpatient providers. Someone who's a reliable, compassionate provider that you can send your patients to. You know that when they get there, they're not going to turn them away, right? You don't want to send them to an outpatient provider that requires 30 minutes or even one visit. I've had some providers say that the first session, the patient doesn't get any medications, right? You go and you meet with the team and you get some counseling and they talk about their life history. And then if they come back the second time, that shows that they're actually willing to engage in treatment. Like I've seen this before. That's not what you want. You want someone who, honestly, the best would be walk-in hours. And so, maybe they have some flexible scheduling. This patient group with opioid use disorder often has trouble making strict appointments. They have financial problems, they have transportation issues. And so if you can develop a relationship with a provider with flexible scheduling, make sure that they're willing to give medications the first visit, and they don't have a lot of hoops for them to jump through. Because at least at first, it's hard to engage in a lot of counseling and other requirements when you're physiologically going through opioid withdrawal. So we treat the withdrawal first. Once the physiology is satiated, then we can move to other counseling and psychosocial methods to improve their long-term success in the program. And so sometimes, you have to go and visit with these providers and see, how they're doing. Hopefully you'd have someone in your healthcare system. It does make it a little bit easier to get buy-in from the C-suite if so if you're in the emergency department and then you're referring to a clinic within the same healthcare system, it's just like, financially better because it's like a self-sustaining model in which you're funding the same system that the patients are coming to. So it takes a little bit of work, but developing those relationships makes it a lot easier for your patients. So why is this all important, right? Why are we spending all this time and energy to try and get people into treatment? And the truth is it's, I don't know, maybe one of the top handful of interventions that we can do in the emergency department. Like the number needed to treat to prevent like adverse effects from stroke and heart disease for aspirin is like, 100 patients, things like that. For opioid use disorder, I think to save a life, it's 52, right? And so it's twice as effective as aspirin. And it's just, these are the numbers. This was from Maryland. They followed clinics throughout the state that were state sponsored to prescribe medications for opioid use disorder, and they looked at rates of death. And so the second graph here, my pointer, there it is. My pointer is intermittently working. Anyways, the second one from the left is your control, right? So these are patients with opioid use disorder. They went to the clinic. They didn't get started on methadone or buprenorphine. And so their hazard ratio is 1, just definitionally. If they were on medications for opioid use disorder, their hazard ratio, adjusted hazard ratio for death was 0.18. So a sixth of what it is if they didn't get any treatment. If that patient then went to or had been in an inpatient detox, you increase your risk of death greater than 5-fold. And if they stopped medications, methadone or buprenorphine, then it was almost 6-fold. And so this, I think, at the same time shows how effective medications are at preventing death. And on the other hand, shows how dangerous periods of abstinence are. And so when you go to these inpatient detox centers, which I think in popular culture is just kind of assumed to be the way that you get treatment for your addiction, it's actually very dangerous because they can go in for a week, 2 weeks, 90 days, 6 months. They lose all of their tolerance to opioids. And then the first time something happens and they return to their chronic disease, which is opioid use disorder, they use the dose that they last used and they overdose and die. same thing for when you discontinue these medications, right? So a lot of time when you're on buprenorphine, I think more than methadone, but you will start to lose some tolerance, and then you go back and use and you overdose. So very effective medications, and stopping these medications too quickly and going to inpatient detox without protective agents like naltrexone are very dangerous. Here's some more data about the effectiveness of medications. These are all retrospective, and so it's not like they split up an equal cohort of patients into each group. It's just retrospectively looking about how patients do. But this first, so chart A, it looks at opioid overdose at 3 months. So who had suffered an overdose after 3 months? And then the one on the right is acute care use at 3 months. So basically urgent cares, emergency departments, who's using resources and who's overdosing. And you can see that patients least likely to overdose and are least likely to use acute care are patients that are on buprenorphine or methadone. Patients that do the worst are those that don't get treatment or go to inpatient detox. And so that's, I think, kind of expected from the prior data that I had shown. So medications are very effective at both reducing overdose and acute care use. Oh, I guess the other thing about this chart, especially with acute care use, is one of the objections you'll hear from trying to get a buprenorphine program in an emergency department is that, we don't want to be the opioid use disorder center of excellence, right? I've heard that before. Well, if you want fewer patients to visit your emergency department with opioid use disorder, the best thing you can do is start a buprenorphine program, because they are then treated for their opioid use disorder and don't have recurrent complications from injecting drugs. They overdose less. And then here's the data that shows they're less likely to use an emergency department. And so if you want fewer patients with opioid use disorder in the emergency department, start a buprenorphine program. Some population level data. This is Baltimore, which has been kind of the opioid capital of the US for quite some time. And you can see that the overdose rate in the 90s was persistently elevated. And then with time, initially methadone clinics started to rise. And then buprenorphine was approved in 2002 for use in the US. So you can see that as buprenorphine, patients on buprenorphine increased, you start to see this slow and steady decrease in opioid overdose in Baltimore. Similar thing happened in France. France had this overwhelming overdose rate of, or not rate, but total overdoses of 564 in 1994. I think Jake talked about how it's 75,000 in the United States. And so their response in France to this outbreak in 94 was to do what we just did, right? They got rid of all these requirements, right? So any provider could then prescribe buprenorphine. It wasn't a special medication. You didn't have to go to a special clinic. And you had increased rates of buprenorphine prescribing. And then, as you can see, what followed was a steady decrease in opioid overdose. This graph looks similar to the one 2 slides ago, but this is talking about duration of treatment, because the probably second or third most common question patients ask and families ask is, how long do I have to be on these things? They think, they've heard of 5-day tapers, they've heard of week tapers, 90-day treatment. That's not what we're talking about. This is a chronic condition, and treatment should at least be 180 days. But the truth is that people that have the most success are on buprenorphine or methadone for life, right? For as long as they have opioid use disorder, which is a chronic condition, they should be on medications. And so you can see here is that and again, this is retrospective, so they likely had some life event that made them come off of medications. Who knows what happened? But patients that only took the medication for 1 to 30 days actually, did worse long-term than patients that weren't on medications at all. People that were in it for an intermediate period of time, from 31 to 180 days, approached the rate of overdose for people that didn't have any medications, and people that were able to be treated for greater than 6 months had a much lower rate of overdose. And it's very similar to acute care use. And so be on medications, and they should be on medications long-term, because once you have opioid use disorder, you've rearranged the neurobiology of your brain, and you will have this chronic draw to return to use. And when you return to use, your tolerance is diminished and you're much more likely to overdose.
Nick, I can add in a little bit on that one, and that, to address the how long do I need to be on this medication question. I'd like to draw the parallel back again to diabetes, chronic medical condition. And, can some patients with diabetes get off of medication? Yes. It's not going to be right away. It'll probably take, several months, if not years, of diet and lifestyle modification before you get to that point where you lost a bunch of weight and now all of a sudden you don't need metformin or insulin anymore. And I think that parallel is quite similar with opioid use disorder. There are usually a lot of environmental factors in play, so if you're able to change those, the people that you're around or the environment that you're in, and therefore your temptations are less, or the cravings are lower. But this is like a very long process. And again, like you said, the data, I think, shows that anything under a year is usually not effective. And there really has to be significant changes that are made if you're going to be in a situation where you can be off medication. And you don't necessarily need to be on buprenorphine, like we mentioned, if that's not for you or you don't feel comfortable with that in your life. You don't like the fact that you're still on an opioid, and having opioid use disorder. Then there are other medications and methodologies to go ahead and explore.
Yeah, naltrexone is a great option. If someone is really motivated, they do a year or two on buprenorphine, their life is more stable, they have a job, they have family support, they want to do a 2-week taper off of buprenorphine and then transition to a long-acting naltrexone injection. I think that's a great strategy. But it's, you need a backup, because I've had patients who are off of methadone for 8 years doing well, something bad happened in their life, and boom, they're right back. So some type of just safety net is really something I hope people do. So this is a slide about some of the themes that we've noticed in successful programs. Right? We've had grants at 75 different hospitals, and some have taken and some haven't. And so what we notice is that programs that do well have support from their department leadership. Right? This is not an ED director that is going to be obstructive or kind of belittle the program. They want this to happen, and the important thing is that they find someone to be a champion of it. And so you have to have leadership support, but then also someone kind of in the middle, right? You want some respect within the group of providers that what they say is right, that they're not going to lead you astray, that they're going to be responsive to feedback, they're going to respond to emails. And so leadership support, and then a project champion who's going to take this and kind of make it their own. And then you'd be really surprised. The pharmacists and nurses often are pretty receptive. You can usually find 1 or 2 in any hospital or emergency department that will want to engage and then talk to other pharmacists, talk to other nurses, because once you get buy-in from your clinicians, you don't want your peers to then get pushback from a pharmacist about this, or get pushback from nursing staff about why are we doing this. So you want kind of every aspect of your department to be engaged. And honestly, the best way to engage different cohorts of your department is to get respected champions with the same background. Ideally, you'd have nurses teaching nurses, pharmacists teaching pharmacists, because everyone speaks a little bit different language. and it just makes it a much smoother transition. We talked about these outpatient clinics. You just need a really good one or two. And then, somewhere to help them get there, whether it's peer recovery coaches, the case workers, case managers, social workers, use what you can, but you'll need someone to connect with that patient and try to make sure that they follow up as planned. And you just want to make it simple. Those two different pathways I had shown were mostly vertical, right? They're not a bunch of webs and different branches to go. There's maybe one or two splits, and that's it. You just want things easy. I said cows 8 or greater, give 8. I think probably 16 is better, but am I sure that it's worth making it more complicated by saying 16 rather than 8? I don't know. I think that there's a lot of benefit to making something simple for people. And so I hope that when you make a pathway that you try to make it simple as well. So we have a frequently asked questions section, and we can open it up. If anyone has any questions. I think the one that I certainly want to address is this. It just comes up the most. Why are we starting someone on buprenorphine? Isn't that just trading, one addiction for another? And I think what this is kind of a bit of a misunderstanding about, addiction versus dependency versus a use disorder. And so it is, right? You are trading someone's opioid dependency to fentanyl or heroin to a physical dependency to buprenorphine. That is true. But what you're doing is you're treating their opioid use disorder. Remember, use disorders typically have consequences. They're using drugs in a dangerous situation. They're having social or physical sequela. So you're getting endocarditis, your family structure is decayed, you lost custody of your kids, right? All this bad stuff is happening to you because of your use disorder. And typically, people on buprenorphine, while they're physically dependent on it, they don't have a use disorder anymore because they can function like a normal person and not have consequences from their use. So I think that's how I would answer that, is that we're not trading one addiction for another. You're trading one chemical dependency. But if that chemical dependency isn't causing you psychosocial stressors, physical health deterioration, then that's what we do a lot of the time, right? Is we treat medical conditions with medications, and that decreases the side effects of having that. And so it's like, again, like diabetes, you have insulin resistance, you supplement your insulin with additional insulin, and it gets rid of the sequela of having insulin resistance. To me, it's very similar. I'll just leave this up here for just a second so that if anyone wants to write down, we can always help. There's plenty of tools at the Community Foundation website. We've had trainings in the past that you can look at, and I think eventually this one will be uploaded as well. We're going to go to couple cases. Here are references if anyone wants to double check. I did have one question, Jake. I was looking at your hydromorphone challenge. I have to imagine those doses had to be oral, right? They're not injecting 18 milligrams of buprenorphine. It's probably oral 18 milligrams. I didn't read the paper, but
I just reread the paper yesterday, and I'm pretty sure it's IV push Dilaudid, and
wow.
I'll double check it for.
That's a lot.
I don't know if I bet the farm on it, but I'm pretty sure it's IV push Dilaudid. Yeah, so that kind of goes in the face of what I had said about treating how to treat somebody that's has a high concentration of buprenorphine in their bloodstream, that you'd think that there'd be some effect of that medication. But I know fentanyl, it has a high affinity for the opioid receptor. So, and maybe there's some pharmacology there that I'm not quite aware of, where the buprenorphine, wins out over Dilaudid. That I'm not 100% sure on that. So, but I 90% sure it's IV push hydromorphone. Yeah.
Well, then maybe there are people maybe they have an opioid use disorder, right? Maybe these are fentanyl and morphine dependent folks. Because I think
The folks did have an opioid use disorder. Yes.
okay.
Yep. Mhm.
And I think I'm certain if I got 6 to 18 milligrams of hydromorphone, I would no longer be breathing.
Right, but if your opioid receptors were
Yep.
blockaded with buprenorphine,
But
you'd have a shot. You'd have a shot at it.
yes, but the first there was like the first 2 weeks, right? They were unblockaded because I think that was
Right. That's correct. Yeah. So
yeah.
those folks, yeah, they were, they had opioid use disorders,
Yeah.
correct. And then
Okay.
actually a criteria of the study was that they were not seeking treatment in order to be in the study. So they were just actively using and yeah.
Gotcha.
Yeah.
Okay. Does anyone have any questions? Otherwise, we'll move to a couple cases. All right. Naomi, can I take over the screen for you now?
Yes, you can.
Sorry, I actually need to. Okay, got it. Let's, I'm going to cherry pick because I don't think we want to do all 6 of these. Let's do. I like these last couple. So I guess I'll read it and then Jake, I'll kind of get your thoughts on it as your approach to it. Does that sound okay?
Yeah, sounds good.
So Maria is 34 and she comes into your emergency department with opioid withdrawal, and we're going to talk about how to address her pain. So she's 34 and she's homeless. She's not a very good historian, and she came to the emergency department by ambulance. Because at the homeless shelter, she had fever, she was agitated, and she had complaints of severe back pain in her right buttock identified at the homeless shelter. And she couldn't stand up. She was just lying on the cot because of the pain. She's been injecting heroin for several years, but now mostly injects intramuscularly or subcutaneously because she can't get into a vein anymore. Previous medical records indicate a history of diabetes, hypertension, obesity, polysubstance use, and bipolar disorder, which is often undertreated due to medication noncompliance and challenges with accessing healthcare. She admits to injecting recently in her right buttock and has had several days of increasing pain, swelling, and spontaneous wound drainage. She admits to some intermittent methamphetamine use, but mostly is using heroin. She says she's using a lot and injecting at least 3 times a day, but can't be more specific. She suggests it's been approximately a full day since she last injected heroin, as she was unable to get up off the cot at the shelter to go outside. She's trying to stay curled up into a fetal position, lying on her left side. She's crying, intermittently yelling at the staff, pushing them away, trying to keep herself covered up, and is very resistant to being examined. She's restless. She complains of severe pain, not only in her buttock, but complains of generalized severe body aches, abdominal pain, nausea, and is obvious rhinorrhea. She will not let the nursing staff attempt to start an IV, draw blood, administer any injectable medication. She finally allows a nurse to obtain a set of vitals. She's febrile, heart rate's 145. She's breathing quickly. Blood pressure is 115 over 77. Pulse ox is 96% of room air, and she weighs 95 kilograms. In the limited examination that she permits, it appears that her right buttock is diffusely swollen, red, indurated, tender, and has a necrotizing wound in the center, which is 6 centimeters in diameter and at least 2 centimeters deep, with copious purulent drainage. She is septic with a large abscess, in need of excision and debridement in the operating room. The charge nurse is asking for an order for a B-52 to sedate this patient so that an IV can be placed and blood can be drawn. All right, what do you think?
That's a tough case. I tend to, obviously she's got 2 things going on, right? She's probably in acute opioid withdrawal, but she has, probably emergent surgical condition that needs to be, needs source control in the OR. So I probably, and I don't think that talking to her at this time about her opioid withdrawal is going to be effective, and her opioid use, that is, she's in severe pain. So my most likely clinical course here would probably just to treat her with opioids with pain. And so even if she won't let us put an IV in, I would potentially treat her with IM pain medication. I don't know what the right answer is because I've never seen this one before. I suppose you could go with buprenorphine, but then you'd be, blockading the mu receptors, and you wouldn't have any ability you would have a harder time controlling her pain that she might have related to the surgery. So curious what the answer is, because I think I would err on the side of just treating her pain with opioids in order to get her under control, and then once she's post-op, then talk about the issues.
I set you up with a hard one, and it's probably a controversial one. I think that doing as you describe is probably what most would do, and it might be the right thing, kind of depending on your anesthesia group and your surgical group, right? You wouldn't want everyone else in the hospital to be mad at you for starting buprenorphine. This prompt was recommending buprenorphine first, because as you mentioned, there's two things going on, right? You have opioid use disorder, and then you have this sepsis. And you could use, intranasal or IM fentanyl or hydromorphone or something like that, and that would work fine. The only thing on the back end would be that it's much more challenging to transition from the opioids for pain to the buprenorphine at discharge. I think that's probably less of a case more recently. I think I've seen a couple case series where addiction services are putting people on like full doses that are on fentanyl or hydromorphone for their pain after a surgery. They're putting buprenorphine patches on people at low doses, right? And so they're slowly transitioning them to buprenorphine. So I think it's less of a big deal. But if you weren't going to do this microdosing strategy with the patches, then the issue is you have someone who's probably needing a lot of fentanyl for the pain, and then you're trying to get them onto buprenorphine at discharge. It's like a little bit of an issue, but certainly it's not a straightforward case, which is why it's a good one.
Have you seen or had any cases like that you've opted for the bupe management in somebody that's likely to go to the OR?
I haven't. I think luckily I haven't. I think it's more and more common for the anesthesia groups to be kind of understanding, because it is in their literature too that the recommendations are to treat the withdrawal. Now, usually the recommendations are that if people are on buprenorphine or methadone, that you continue it, because years ago, right, you were tapering off buprenorphine before your surgery, which was a disaster. I understand it makes it easier for your pain to be controlled with fentanyl, but you're having all these people with opioid use disorder who need surgery, who then have opioid withdrawal, and so obviously continuing the buprenorphine in those cases are better. Whether or not you start it new is, I think, more controversial and more challenging, but seems to be where it's moving. Whether or not that's permeated, all hospitals, I think is almost certainly to not be the case.
Yeah, I'd actually like to discuss that. I've seen a few policies and things that have come through regarding perioperative buprenorphine, and so. But usually I'm like, oh, that doesn't affect me, but it definitely would in this case, And so, and if that's the preferred method, so certainly being a proponent of bupe, I would probably prefer to go that route too, and I know how to do that. So,
and it may be one where you call anesthesia and just say, look, in surgery, I have this lady who has an opioid withdrawal. I would like to give her buprenorphine, but if that's going to blow up your whole operative case, then we can just do something else. And I think that's probably the more diplomatic way to do it. But I think we should be prepared that if they say, go ahead and give them the buprenorphine, that we're not afraid to do that too.
Yeah, but the next case I see like that, especially if I'm doing a consult in the ED, I would definitely open up those channels and see what they say, because it certainly does happen, fairly frequently where something is going to be needed, some type of procedure, whether it's a bedside or, an OR procedure. You see it fairly frequently, once or twice a week, that, there's some complication that's going to need a surgical intervention.
Number 2, so she's going to need a CT and a procedure in the operating room. Should that change our initial management? Well, I think we already talked about it. So this is I took all these from the PCSS, right? They're the ones that did the 8-hour session years ago. And so this is where these are coming from. But they recommend treatment for opioid withdrawal, and that an IV would be difficult. So we talked about how you could do intranasal and IM medications. And then they felt like administering the buprenorphine, but early would be better. You can get an IV then, and then give her antibiotics, etc. It says administering buprenorphine will not impede operative pain management. I think that's true in ideal world. I think, everyone has variability in what their anesthesiologists are comfortable with, which is why, maybe talking to them, so what their preferences are is depending on where you are, it may be best. I think, I've seen published guidelines in which they want treatment in places like Stanford and stuff like that. Fine, like do it. But that's not the place I work, and I think my anesthesiologists are wonderful, but I'm not sure that they would all love me starting buprenorphine in someone right before surgery. She receives buprenorphine 16 milligrams in the ED and then gets an IV. She gets blood drawn, labs are obtained, antibiotics and lactated ringers are given. She's able to cooperate for a CT scan. She goes to OR and is admitted to the hospital. The hospitalist is contemplating an effective medication plan to treat her opioid use disorder and manage her pain. So this one I think is also a good one.
In this case, we've already made the decision to start bupe, and as you mentioned, bupe is effective with pain. So I probably would, since she got 16 milligrams in the ED, she's probably going to need a higher dose. So at the very least, 8 milligrams BID would be where I'd start, and she may need a TID. That would probably be my recommendation. So as needed. Yep.
Yeah. I think this gets to the principle that you had mentioned how buprenorphine is good for pain for 4 to 8 hours or so. And so its ability to reduce cravings lasts for a long time, but there's this spike in plasma concentration initially where you get a lot of analgesia from it as well. And so without increasing your dosing, you can just split the dosing and get more analgesic effect. And so that's what they're doing here. Is they have her on 24 milligrams, but they're splitting up 3 times a day so that she's getting some pain relief more frequently. And then with dressing changes, painful things, you can either increase that dose of buprenorphine, or you can give fentanyl as well in little pushes to try to give her a little bit extra. But I've split buprenorphine dosing for several patients that have had things like kidney stones. They're going home. I just tell them, you're on 16 a day, just split that up and either take it twice a day or split those in half and take it every 6 hours. And it's worked well. Maybe we'll do one more and we can talk about
I just want to give a heads up. I'm getting a Henry Ford mandated computer restart here in about 5 minutes. So if we're not done, I will just log off and restart and log back on, but we can.
I think we'll be done or close enough to being done that you won't need to log back on. So this is one kind of about clinical management and treatment goals. So we have a 19-year-old female university student who comes asking for treatment of her heroin use. She's been smoking heroin for the past 15 months and smoking daily for the past 3 months. She's now using 1.5 grams a day. Some of her friends are now switching to IV use because it takes less heroin to keep from getting sick. She says she does not want to do that, but may be forced to because she cannot keep paying the extra cost of smoking the heroin. She's used all the money her parents gave her for school expenses to buy heroin. Her credit cards are maxed out, and she's borrowed money from her friends. Until last semester, she had an overall B average, but this semester she is in academic difficulty. When she doesn't use heroin, she has muscle aches, diarrhea, insomnia, and anxiety. She recognizes the symptoms as heroin withdrawal and was surprised because she thought she could not develop dependence by smoking. She has no prior history of treatment for a substance use disorder. What's your diagnosis?
I'm going to go with severe opioid use disorder.
Yep. I think, there's mild, moderate, and severe opioid use disorder, and almost everyone I see is severe. It's not so hard to get 6 line items there with, risky use, medical consequences, right? If they're in the emergency department, they've had an overdose, they're usually injecting, it's usually by themselves, right? There's multiple things you can check off that make this a severe use disorder. Is she a candidate for treatment?
Yeah, absolutely.
Everyone is. Contraindications for anyone that's wondering, usually is severe hepatitis. That's like the thing that you have to be worried about. So if someone doesn't have severe liver disease, they are almost certainly safe to start buprenorphine. Treatment goals. What would you want for this young lady?
I think, the goal is a cessation of all, opioid use essentially, and return, all the psychosocial improvements that you might expect with that, with, return to school, financial difficulty resolution, etc.
Perfect. What's your initial treatment plan?
Yeah, I'd probably start her on 8 milligrams BID for at least a week, and send her, to a facility or to a clinic that I know is going to address all of her needs, essentially.
Yeah, perfect. The clinic physician gives her a prescription for 6 days of buprenorphine at 4 milligrams a day, and she's told to participate in the clinic's relapse prevention workshop 6 days a week and to schedule individual counseling at the clinic once a week. She returns 3 days later, having taken 8 milligrams a day for 3 days. So she did what you would have done, but not what this provider did. She has not attended the relapse prevention workshop nor scheduled an individual counseling session. The counselor is not available to see her when she comes. So this is kind of what we're talking about when I was talking about the clinic you send people to. You don't want to send them to this clinic, right? A underdose, a lot of barriers, these workshops, go to counseling, do all this stuff. So what should we do now?
Yeah, I think we obviously know what she's requiring, so we should change her prescription that would, meet her, her requirements, and, make sure she's got a warm handoff to a clinic that's going to treat her.
And I think, the point is you really can't work on this counseling and psychosocial stuff until you're physiologically in a place to do that. And so medications first, everything else has to wait. Part 3, she returns the following day at a time when neither the group nor the counselor is available. She's told she has to attend the relapse prevention workshop in order to get medications. She does not return to the clinic for 4 weeks. When she does, she's smoking more heroin than before, but having no difficulty with finances because she's dropped out of school and is working as a stripper at a local gentleman's club. What would you do now?
I think we need to get her back up.
Yeah. So, so she's being underdosed. She's being kind of in a rigid clinic that isn't taking into account that, if we don't kind of emergently act, then this person is likely to succumb to their disease, which, in this case, this person did end up dying from an overdose. So flexibility in our clinics and treatment is really important. So I think that's all we have. I thank you all for joining us today. And I hope that you're able to take away a couple of key points into starting up and maintaining your own treatment pathway for your patients with opioid use disorder. Thanks so much.
Thank you, Dr. Rodemaker and Mantipel, for sharing your insights and expertise in the space. Obviously, I'm not in your world, but I've learned so much already. So I'm just really fortunate to have both of you guys present on this topic. We know how important it is, how passionate you guys are, and we just appreciate your time doing this. Also want to thank the Community Foundation for Southeast Michigan, CFSEM, and MHA Keystone Center colleagues for making this possible. For everyone on this call, just a couple things before you go. If you have any additional questions for either our guest speakers, MHA or CFSEM about these programs and opportunities, you can reach out to us at Keystone Mailbox at keystone@mha.org. And then also be on the lookout for other learning opportunities such as this one. You can visit our MHA events page to find more information on that. Aside from that, again, I want to thank you, Dr. Rodemaker and Dr. Manifel, and we really appreciate you guys' time. All
Thanks,
right,
Clarence.
take care.